Well, good afternoon, everyone. Welcome. So yesterday we talked about full arch, completely digital full arch surgical prosthodontics. This afternoon we're going to be talking more about single tooth restorations or partially edentulous patients and looking at the ways that digital technology can be used to enhance our implant restorations and all of the procedures that go into the planning. And with a synergistic approach, that is the combination of the two give us results that are greater than the individual parts in there. So I bring greetings from Seattle, Washington, where I'm a professor, and we have been working on this project for these projects for about a year and a half now with the Biodenta company. And if we look at when we were at the meeting 2 years ago, we saw some big developments with the Trios color intraoral scanner. And if we look at what's changed since the meeting 2 years ago, I think we've seen some pretty big improvements in terms of improving the scanning technology. The milling machines have been improved so that they have greater accuracy, so that they are miniaturized, and we'll see today how we have some sizes that are almost portable, and also now have wet milling, which allows us to also mill ceramic restorations and are much more affordable. The prices are really coming down on these, along with, very importantly, our software developments that have made all of these different levels work better. And we've seen introductions of either some new materials too that also enhance our results. So the benefits that would be provided both to the doctor as well as the dental technician are that with these systems we can expand our capabilities, do more things. We either, again, the doctor, the technician can have more control, increase our independence so we can do these things ourselves, be self-reliant, which I like as a prosthodontist. We tend to be kind of control freaks. And also then with the miniaturization, we're significantly reducing the footprint of the equipment that goes, because we all have challenges in our offices in terms of space. So in terms of these new systems, then we can scan the patient, we can scan the models, or we can also scan the impressions. So we have all sorts of sources that we can go to provide for our acquisition of these various images. We can then go ahead with these new systems and plan and design to really a broad range of applications, both teeth and implants. And now we can mill with, in terms of PMMA temporary restorations, either for tooth or implants. We can provide and actually mill out surgical guides in our milling machines for the smaller cases, single tooth restorations. And we now have systems that have come down significantly in cost that we can do wet milling with these systems. So if we look at kind of the evolution of these different systems, we have the huge systems that are the size of a room, and those still have indications for the larger laboratories. We had the lava system, which was also fairly significant, and then some of the systems developed by, for example, VHF, which are significantly reduced in size compared to these other systems. So we have coming out now a system from Velon through Ivoclar that has multiple discs on there that does wet milling. They call it the hybrid. Biodenta has the 2000 model that we can mill one disc at a time. And the new system we're going to be talking about today is the Biodenta DS 1300, which is a wet milling system, and it is, in fact, pretty portable. So this is the system, the 2000, that I use in my laboratory at the University of Washington. It's a dry milling system, 5-axis, and it works really nicely for milling PMMA, for milling zirconia prior to sintering. And it's really worked very well for us. So yes, this is fairly big, but the problem is, in order to make this work, I need to have a vacuum. I lose this space with a vacuum that's almost a meter tall that's inside there. So, and you have to have the electrical facilities to run all that. So it does take some sizable space. A very exciting introduction then of the Biodenta DS1300 is that it's all incorporated into one system, significantly smaller footprint, and not that it's very sexy, but if you look at what's involved in terms of it has to filter the water and it has to have an emulsion in there for milling, and that is simply housed in this drawer, which can be slid out, and there's either you can do it old school here, take it out, go over to the sink and rinse that out. Again, everything goes into that one drawer. I don't need to have the big vacuum underneath. Or you can also then just pull the drawer out enough, undo the spigot on here, and drain the fluids out of there to clean it. So it's really very, very compact and a lot easier to change the water and clean that out for our system there. And again, this is a wet milling system. So now we have all sorts of opportunities to mill ceramic restorations, essentially doing chairside or in your laboratory milling of the restorations. And we can do, for example, the Emax system with the blue blocks and mill those out. Again, with our wet milling system, and we're using the small mounts on those, and in a fairly short order then produce those restorations. And here we have it as milled. We have a very nice fit to our stock abutments that are hybrid abutments that are provided by the company. And we know then we can then proceed on, take a diamond disc and cut the sprue or connection off, and then we're going to put that in our oven and we're going to go through a sintering process. And what's nice about this is as we can see, it starts the crystallization process. We develop translucency and shade in the ceramic, but the significant advantage of this is there is no net shape change. So the fit is as good as when we milled it out. So we start out with something like this and then go ahead and sinter that. And then we're going to take our new titanium hybrid part here, the abutment with the screw, and you can see the seating surface that has been milled on there. And that then allows us to go ahead and analyze the fit, and as good as it was during the sintering, before the sintering process, and engaging the internal hex and the conical connection of the implant, and then would allow us then to do a hybrid titanium interface with the implant, and then connect that to the lithium disilicate screw retained crown. And again, whenever possible, we'd like to have a screw retained restoration. And so with this then, as this example here, I don't have time to go through the whole design process, but we've gone ahead and designed the single crown restoration. We've gone ahead and nested that in the block, and again, you can see this is a block, not a disc, and it can hold up to 3 specimens in there. And if you would just go ahead and click on the little bar here for me. So this has, I believe it's 8 water jets that are cleaning this and keeping it cool. And we're now milling this out of a PMMA material that is layered with an enamel, going from enamel to a dentin shade on there. And it can mill these very quickly. We're typically looking at 18 to 22 minutes in order to complete a restoration. And this material, again, is fairly soft because it is polymethyl methacrylate, so it can be milled in fairly short order. So this is an example of the block, and you can see the enamel portion here and how it's layered, and really produces very aesthetic restorations. Now, again, this is the temporary, but it's the same design process as if we were doing the ceramic restoration on there. And here's just an example. So we're cutting off the sprues. You can see the milled seating surface on there, and we try that in, and we can go ahead then, trim that off, polish it up, and we're ready to proceed there. And we typically use something like the Brasser temporary polishing system, and then I keep a 1-inch rag wheel in there that we sterilize with every patient, and we can achieve a very smooth, very glossy surface on there that is plaque resistant if we're going to be using that as an immediate, a temporary restoration, or also providing a nice surface finish on there. So just very quickly then, a technique that I like to use is we use the plumber's tape on that. We get our hybrid abutment from the company, and we have actually milled the screw access hole through this individual crown, and we're going to use some type of a cement. In this case, it's Variolink Aesthetic. It's a dual curing cement. I want to go ahead and seat, have my screw down there, and I want to fill up the screw access hole because I want to prevent the cement from filling that hole. So this is a very quick and easy method to pack that in there. And you can see now we've obturated the space, so I don't have to worry about the cement in closing or causing problems with the screw inside of the abutment. And then we can go ahead and cure that and then clean it up. So we have a nice clean interface here with minimal cement at the interfaces, and this is going to keep the gingival tissues very happy as they're going through the healing process on there. So we've seen some improvements and actually some new systems. So this is the original Trios intraoral scanner. They now have the Trios 3. I've only just seen it very briefly, but it looks to be very interesting. Another exciting introduction is their shade selection system. So we can just simply scan and just go ahead and mark the areas where we'd like to determine what the shades are. So this is a nice addition to the existing system that can help you choose the shade if you don't feel very comfortable with that. So with showing you these kind of examples here, I'd like to share with you one patient treatment case. We'll kind of go from start to finish here in the time that I have allotted. And we're going to talk about the different ways that this can improve your practice and, again, make you self-sufficient, going from the design process to the milling and then the execution of the restoration. So this is Melody. She has, let's see, what is that? That's a 1-5 in the European method there, or tooth number 4 in the United States. And that tooth is failing. She has a fairly high smile line, so always with implants, yes, we want to match the white, but it's also important that we have the pink there. We have the gingiva as well, and that's going to be a consideration with her very high smile line there. She shows about another 4 millimeters of gingiva. So we want to be careful with how we handle those tissues, and we can see then the area that we are going to be concerned with. We look at the plane of occlusion that we have and the opposing teeth for that. And you can see here that the tooth has decay, the clinical crown is gone, and the root is decayed as well, and it's going to have to come out. So if we take a little bit closer look then at this, you can see how the tooth has drifted towards the distal. So we have an unequal distribution of space in here, and in fact, it's almost up against the molar tooth, and we've created a larger space between the premolars. We can see that we've also lost the papilliform in this areas too, and this is somewhat suspect looking as we look at it from the occlusal aspect on there. And if we look at the X-ray, you can see the angulation of the tooth. So when we place the implant, we do not want our twist drill that we established the original, the first part of the osteotomy, we do not want that to follow the path of least resistance, which means as you put the burr in there, if you're not using a guided system, it very easily wants to go in this angle. And what we want to do is put a vertical implant in there. So we can get a cone beam CT, allows us to look at this in 3 dimensions. We can see that this tooth has in fact had a root canal and is all decayed, and again see the angulation that shows through in this 3D dimension. And so if you could also click on this one for me, I think it's down in there. So this is just an example where we went in with the Trios Inteller a scanner, And I guess the video's not working there, so we'll just go ahead. But basically, this just allows you to analyze in 3 dimensions, look at the occlusion on there. Sorry, I don't have control of this. And so we can then go ahead and proceed with the design process. So the first thing we're going to do is to develop where we'd like the crown to be. So we're going to look at the opposing occlusion. We're going to look down the buccal corridor, and we're going to line up that tooth accordingly. And then from that, we can then import the cone beam CT into the 3Shape implant studio, and we can start to figure out our process. So what we did, we had to kind of move and cut some of this off because she had a lot of existing gold and porcelain fused to metal restorations, and we were getting a lot of scatter off of those, but we're still able to see the important areas. And you can see here the angulation of the tooth, and now what we're going to plan on doing and lining up the implant. And it allows us to look in 3 different dimensions on here. And let's look at this one. So we're gonna line up this tooth with the opposing, the way we'd have a normal horizontal overlap there. And then with this will then tell us where our screw access hole dimensions are roughly. And then we can look at the alignment of the implant. And you can see how we are significantly changing from the existing route to a more vertical direction. We have a very vertical wall on here. And we have to be careful in that we want to maintain at least 1.5 millimeters of bone or grow that and have that distance between the tooth and the implant in order to support the interdental papilla. So with this, now looking from the facial on here, again, you can see what our plan is to correct that direction and take maximum advantage of the bone and get the longest implant possible. From there, then, we'll go ahead and do our surgical guide. And you can see, very typical, it's going to snap on or be supported by the adjacent teeth. It's very important that the surgeon hold that down securely as he or she is doing the surgery. And that will then help orient the osteotomy procedures just as we have oriented. One thing nice that 3Shape has developed is in their implant studio, they have a surgical report. So it's, I'll say it's idiot-proof, but it may not be oral surgeon-proof. But you can see here we're talking about the position of the implant, the manufacturer. We're going to use a Biodenta tapered implant, B2 with a 4.1 diameter on there, a length of 10 millimeters, and it's blue on there. So we've got all that spelled out. And this is a 2-page report. So it gives the surgeon those dimensions, and it has the implant position indicated on there so that hopefully we can keep them going in the right direction. So we can then, with that guide made, we can take our disc, and in this situation, we're actually going to be using the 2000, the dry milling system, the 5-axis system. We're going to get a clear disc in that, and then go ahead and mill that out. Doesn't take too long, and we can see then how we've milled out the surgical guide, and you can see it's kind of rougher along here. But then once we get down to that seating area where the metal is going to be engaging, you can see the roughness here where it mills it very rapidly. Precision is not needed. But once we get down to this interface with our insertion cylinder in here, which lines up with the hex on here, so it's very precise for the position as well as for the depth on that. And so now we've inserted that metal in there. We know it's a blue one for the B2 4.1 millimeter diameter, and now we're ready to go for our surgery. So again, we provide this to the surgeon as well as the surgical guide. And just to kind of show you the armamentarium, we just pulled out the burrs. So this is a tissue punch. We're probably not going to need that in this situation. 2 millimeter twist drill set for the proper length on here. And then we have the insert that goes into that fits very precisely and will then locate and direct our 2mm twist drill. And then as we go to the 3.5, and later on we'll do the 4.1, and then we've got the implant insertion portion on there as well. So this is Dr. Michael Ye, who went through our prosthodontics program at the University of Washington, and he practices down in Federal Way, just south of Seattle, and he's going to be doing the surgery, and I'm going to be kind of the support guy, I guess the lab technician, as we go through these procedures. So we're going to go ahead and administer local anesthetic. He's also using nitrous oxide. We've got a little show business. We're recording video and shooting pictures as we're doing that as well. And he's put together a great team. So the first thing we're going to do as we're waiting for the anesthesia to set in is we just want to make sure that this seats down all the way. So I'm making sure there's no space here on any of these surfaces. So I'm looking around there on the buccal. I put my mirror to look on the palatal to again make sure that's very intimately adapted to the teeth. And now you can see I have my direction lined up for this. We remove that, and now we want to do an atraumatic extraction. So no more grabbing it with your forceps and rocking it buccal lingually, because you will probably fracture off the buccal plate. And as Dave Garber has said, the bone sets the tone here. You have to have bone or you're not going to have the gingiva there. So we're using a very flexible periotome. We're going down and then cutting through all the ligaments so that we can then remove the tooth carefully, because we want to preserve all that bone because we're very thin on the buccal surface. And all we're doing now, it's so loose, we're just basically grabbing it with the forceps and atraumatically removing that. So the next step is very important. We're proposing to do this as a flapless procedure. So the first thing we're going to do is take our metal instrument and we're going to run that across the walls. So yes, the proximal, I want to see if there is any bone between the tooth and the implant, but the most important place is to go down to the apex and run that up the buccal surface. So I want to make absolutely sure I have intact bone. No fenestrations, no dehiscence. I want solid bone all the way up there. And in fact, we did have solid bone, so we could go ahead and proceed with the doing it in a flapless manner. If we did not, then we're probably going to have to make some incisions here and do some grafting because we need that bone to support those facial tissues, again, because of her high smile line there. So this is what it looks like. So you can see that wall of bone. It's kind of going down because of the angled root that was in there, almost up against the tooth. And we've got the void that is more in this area. So if you were not using the guide and you just went in there with a twist drill, it's really, really difficult to keep that directed in a vertical direction in that position. So the burr kind of wants the path of least resistance, and there's a tremendous chance that you'll end up with preparing a misangled osteotomy, and the implant then will follow that situation. So we can see here then as we snap this on, we have our guidance in terms of the precision placement so that we can avoid this angled placement in the canal. And then we're going to go ahead and place our insert there and then fire up the drill, and we're going to be using water for this, and we go down until that seats all the way down. So we're holding the guide into place, holding this up against the teeth, and going all the way down here so that we're going all the way to the depth that we want to achieve for that. Then we're going to go to the 3.5 drill, which is the protocol for the biodenta system, and it's the same process with the water as we follow that, and we're basically guided to that fairly simple surgery procedure. Even I could do it. And then again, we're making sure that we're seated all the way down there because we are aiming for some precision in the placement in all three dimensions of the implant. And then according to the protocol for biodenta, we're going to go to the 4.1 drill in here, and again, that will be guided into position. And with that completed, we're now ready to seat the implant. So you can see here, one of the special features of the Biodenta implant is that it has a gold anodized surface for about 1.5 millimeters of the neck of the tooth. So that helps with our gingival aesthetics if we have very thin tissues, and helps to reduce the show through of typically gray implants through those thin tissues. So we're going to go ahead and put this on low speed. This device engages this implant very well, but again, we always want to keep it up. We don't want to go vertical. We don't want it to go down and have a drop on the floor. And again, we're just going to go through, this is turning about 15 rotations per minute, and just slowly seats down into place. Again, going to the directed depth on there. So the implant has been placed. You can see that we have it, it looks like it's centered fairly well, but because of the shape of the extraction socket there, we have a fair amount of the implant that is not engaged in bone. And at this point, we're at somewhere around 12, 13 Newton centimeters in terms of the insertion torque. But you can see we got the implant in the right position in terms of mesiodistally. So we're looking straight down the proximal walls there. So we'll have a nice path of insertion for our screw retained prosthesis. And also then is positioned buccal lingually so that we'll have the screw access hole in the middle of the occlusal surface on there. So we always want to take an intraoperative x-ray before we start doing anything else. And we can see that this is seated down into place the way we're looking. And you can see the void in here because of the larger area of the socket. Now, you can see that there is bone here. This looks, again, it's from this angulation. It's kind of coming more for the distal. So it looks like in the x-ray, it represents less than there is actually there. But again, now we're happy with how the implant is seated, and then we can put a cover screw on there and start to do some of our grafting procedures. So Dr. Ye has grafted this area around the implant, and then we can go ahead, and I'm going to show you two methods of handling this. So one would be a immediate provisional restoration that is non-functioning. So we definitely want to have this clearly out of occlusion by a millimeter. We want to scare the wrath of God into our patient that if they chew on that they're going to cause failure of the implant. So really need to be careful about that. We've got our nice contours that are all polished up. And again, we just put that on our screwdriver and use that to deliver the provisional restoration into place. And we have now then seated that until it drops down into the internal hex, and then screw that down into place. So the proximal contacts have lined up very nicely. We've got the screw access hole right on the money, so that we have a nice thick wall of material here on the buccal. And then what we're going to do is take this, and Dr. A is going to put some grafting. He made some PRP material, and he then created that in such a way that he had a little hole on here, and he seats that down, and he uses the restoration to then seat that in place. So in this case, we're doing a custom healing abutment, and we're using that to then seat it into place. So I don't want to do a immediate fixed provisional because we only had, and he cranked it up a little bit more, but we only had about 15 Newton centimeters. So we're just going to put this immediate custom healing abutment, which will direct the healing of the tissues and help maintain the tissue levels on there. So we use this then to seat that down and deliver the grafting material into place. And now we've got a nice cover over it. It's well out of occlusion. And this big void that we had here, because again, that distal angulation of the tooth will then be filled for that. And now we have our post-operative x-ray with all the grafting, and you can see we've got a very nice, thick, juicy distal wall on there that will be very stable and will help to promote the development of the interdental papilla during the healing process as directed by the contours of our custom healing abutment. So after the osseointegration period, we're ready to go, boom, right in and make the final impressions, and we can do that with the scan body. So this was our result, and you can see we lined it up, and we're away from the anterior wall of the sinus. We've got a nice thickness of bone, very safe between the tooth and the implant. And maybe we had a little luck in there, but it worked very nicely. It went exactly as we planned. So this makes, no matter how good of a surgeon you are, this makes you all that much better, makes it more predictable, makes your life less stressful. And Lord knows we have enough stress in our lives as practicing dentists dealing with our patients and our businesses. So I'd like to thank Dr. Ye and his crew for helping us out, and for my right-hand man there, Nicholas Rhoda, who's honorary dentist and dental technician, and is the whiz kid on these digital systems there, and really happy with the results that we're getting. And hopefully you've got a few ideas of where we're going with digital dentistry, how we can use that to enhance our results and develop greater predictability for our restorations. This is my email address at the University of Washington, so if you want to contact me, feel free to email me, and I'd like to thank you for your attention.